Good evening, good afternoon, dear colleagues and friends. On behalf of the Asian Pediatric Pulmonology Society, it is truly my pleasure to welcome you to the 12th APPS Grand Round on an unusual obese child with hypoventilation. I would like to express my heartfelt thanks to our host, Beijing Children's Hospital, the National Center for Children's Health, and the China Medicine Education Association Pediatric Committee, led by Professor Kuling Chen, for making this session possible. A very special thanks also goes to Dr. Daniel Ng, the founder of APPS, and the driving force behind the scene of every grand round. His tireless dedication has brought us together and allowed this program to grow. It is my great honor to introduce our moderator, Professor Kuling Chen, who leads at both Beijing Children's Hospital and Shenzhen Children's Hospital. She also serves as president of the China National Clinical Research Center for Respiratory Diseases, the China Medicine Education Association Pediatric Committee, and the Asian Society for Pediatric Research, among many other leadership roles. Her outstanding contributions continue to inspire us in Asia and around the world. Finally, thank you all for joining us from across country and time zones. Your presence, contributions continue. I'm looking forward to an engaging and fruitful session together. Now, I will pass the microphone to Professor Kuling Chen to continue this session. Thank you.
Okay, dear Professor Prosipan, and thank you so much for the introduction. Professor Daniel Wu and Professor Kuputano and Professor L. Ten Edge, Professor Xu, and dear council members of the APPS, colleagues and friends, it is an honor for me to stand before you today at our 12th Grand Round, join together today's case discussion focused on unusual obese child with hyperventilation. Please let me introduce the presenter for today, Professor Xu Zhifei. Professor Xu Zhifei is from the Department of Respiratory Medicine, Beijing Children's Hospital, Capital Medical University, also the China National Clinical Research Center of Respiratory Diseases, National Center for Children's Health, China. Next, let me introduce our three panelists. First is Assistant Professor Magic Attini. He is the pediatric pulmonologist and a sleep physician at Al Jalila Children's Hospital, Dubai, United Arab Emirates. The second panelist is Assistant Professor Tairaji Kupatano. He is pediatric pulmonologist and a sleep specialist at the Ray Masudo Hospital, Mahidol University, Bangkok, Thailand. Last but not least, Dr. Daniel Wu. He is the honorary consultant at Department of Pediatrics, Hong Kong, Sanatorium and Hospital, Hong Kong. Now, let's officially start our discussion. I look forward to your valuable insight and contributions. So first is Professor Xu Zhifei to present the case.
Thank you, Professor Shen, for your introduction. And good morning, good evening, everybody. It's my pleasure to be here. So please, would you please share the screen?
Shared.
Shared. Yes, thank you. Okay, I will start. Today I will present a case. He's a boy, 9-year-old and 4-month-old boy. His chief complaint was an episode of loss of consciousness months ago with persistent fever. And he was admitted into the local hospital. Then he was diagnosed as pneumonia. The pathogen is influenza H3N2, and his pneumonia result leading to respiratory failure type 2, and also he was suspected as encephalitis. Next, please. Then in hospital, he was mechanically ventilated for 20 days, and then the non-invasive ventilator was used because of he has persistent CO2 retention, and he was unable to withdraw from NPPV. Besides, he had recurrent fever despite use of antibiotics or steroids, and he had normal CRP and PCT. Then he was referred to our hospital for further treatment. Next, please. Past medical history, his normal term, natural birth, normal weight, and then he started his symptoms since he was 3.5. He had rapid weight gain. His BMI changed from 28 to 33 at present, and he had polyuria and hyperphagia, and also he had behavioral changes. He was irritability, and he had chronic constipation, and also hyperhidrosis. Besides, he had recurrent infections when he was 3 years of age, monthly episodes of respiratory infections. Most of them are upper airway infection, and some of them are bronchiolitis. Usually, the pathogen is virus. He had normal IgA, IgG, and white blood cell count. And then since he was 6 years of age, he had persistent fever for 2 months. And he had persistent fever despite antibiotics and anti-inflammatory treatment. However, there's negative sepsis workshop. Also, the temperature normalized when the weather became cooler in the autumn. Next slide, please. Here is the timeline. And when he was born, there was uneventful. But when he was 3.5, he had rapid weight gain, polyuria, hyperphagia, behavior changes, and chronic constipations. And when he was 6, he has persistent fever for 2 months at age 6. And also the temperature normalized upon the arrival of autumn. And now, when he was 9 years of age, he was admitted to our hospital because of pneumonia and respiratory failure type 2. And he came to our hospital because he was unable to withdraw from NPPV. Next, please. Family history, there's nothing special. His father and mother healthy. He had an elder brother healthy, and no family history of major illnesses. Next slide, please. On physical examination, temperature is normal at that time, blood pressure is normal. His height is 129, weight is 56 kilograms, so the BMI is 33. So he has obesity and the tenor one. There's no enlargement of tonsils, and the myopathy score is class 1. In general, there's no cyanosis, no dysmorphic features, no big enlarged lymphocytes, and also the lung, there's no respiratory distress. The cardiovascular system is normal, and soft abdomen, no tenderness, no distended skin. And also on neurological examination, there's strabismus, but he is alert, good responsiveness, normal speech and hearing, normal cranial nerves. There's normal muscle strength, muscle tone are normal, and normal tendon reflex. Thank you. Next one. And here was his growth chart at birth. It's within the normal range. Next slide, please. Next one, please.
So it's done.
Yeah, it's a bit late between. Yeah, okay. So here is when he was 3.5 years and 9 years old, when he was admitted, when he was 9 years of age. So we can see that there's a rapidly rising weight before 3 years old. And he has decreasing height velocity from 3 years onward. Next one, please. Next, please. And this slide shows his BMI score. Also, it's had much higher BMI score when he was 3 years of age, and now when he was 9 years of age, is still a very obese child here. Next one, please. On laboratory investigations, the blood gas shows the pH 7.38, and he had elevated PaCO2, which was 75 millimeter mercury, and also the BE is 19. It changed. Can we? Okay.
No, it's not changed. Yeah.
Okay, so the CT showed a report pneumonia, and the pathogen showed influenza A virus, and also the bronchial lavage showed streptococcus pneumonia is positive. Next one, please. The endocrine and metabolic studies shows that the blood sodium is elevated, and also he had hyperlipidemia, which showed elevated cholesterol and triglyceride, and also the CRP is normal. The HbA1c is normal. The abdominal MRI enhancing lesion shows there's an adrenal nodular, which suspected with adenoma. The brain MRI shows his pituitary stool was thin, but otherwise normal. Next one, please. The hypothalamic functions show that the antidiuretic hormone secretion status was normal, so there's no evidence of diabetes in insipidus fetus. But he had polyuria with hypernatremia with poor water intake. His morning cortisol level was normal, and the sex hormones was normal. The thyroid function test was normal. However, he had decreased levels of insulin like growth factor 1. Next one, please. The echo of the cardiology was normal. On ophthalmology examination, he had the visual accuracy poor and has a non-paralytic strabismus and severe right optic nerve dysfunction. He had mild intellectual disability, but he can do self-feeding, toilet, and shower. Genetics, there's negative for pathogenic variants. Next one, please. This is his sleep study. The polysomnography showed the AHI was 4.7, and OAHI was 2.8, and CAI was 1.9, and the lowest SpO2 was 63%. The average SpO2 was 91%, and his highest TCP transcutaneous CO2 was as high as 90 millimeter mercury, and the average CO2 was 78 millimeter mercury. And from this slide, we can see that he has a high CO2 and also a low saturation. Besides, we can see that he had a paradoxical breathing. So maybe it's obstructive hypoventilation is also be suspected. Next one, please. Here's the hypnogram. So almost all the time, the CO2 is above 50 millimeter mercury. So it's around almost 99% of sleep. He had elevated CO2, more than 50 millimeter mercury, and almost 80% of his sleep, he had CO2 above 75 millimeter mercury. Next, please. So we try to give him oxygen therapy. With the oxygen therapy, his saturation improved, getting better, but he had worse CO2 as high as 80 to 85 millimeter mercury, and still he had paradoxical breathing during REM sleep. Next one, please. Next, please. Yes. So the questions here, please make your choice.
Okay. Thank you. We're seeing the results now. So we have about 5% mentioning that this is congenital central hypoventilation syndrome, 23% saying it is obesity hypoventilation syndrome. A large majority say it's about 59% saying it's rapid onset obesity, hypothalamic dysfunction, hypoventilation, autonomic dysregulation, which is known as ROHHAD, and about 14% saying it's Prader-Willi syndrome. We don't have any answers for none of the above. So this is good. Thank you. Okay, so what we'll try to do is try to dissect this and move through the diagnostic challenge here, hopefully reaching the diagnosis and having a good rationale. So we want to highlight the key points here from the pertinent respiratory and sleep findings. We have small tonsils, we have a child with obesity, and what we have is compensated respiratory acidosis, as we see a PaCO2 of 75% with a bicarbonate of 44 and a positive base axis of 19.3. The polysomnography shows mild obstructive sleep apnea, And we have evidence of hypoventilation meeting the American Academy of Sleep Medicine criteria of more than 25% of sleep above 50%. We have also evidence of hypoxemia with an average oxygen saturation that is low at 91% and the nadir at 63%. And what we see here is that oxygen therapy did improve his oxygen saturation. However, the carbon dioxide levels did not normalize, but actually did slightly go up. So overall, we have hypoxemia secondary to hypoventilation. Next, please. Now, when we look at hypoventilation, we know that it is related to inadequate minute ventilation. And minute ventilation is guided by the amount of tidal volume that we take and the respiratory rate. The higher they are, the more likely that we are able to get rid of the carbon dioxide. So when it's inadequate, we end up with hypercapnia. With carbon dioxide, there are 3 surrogate markers that we can measure carbon dioxide with a blood gas, with an end-tidal CO2 through a nasal prong, or through a transcutaneous CO2 measurement. Next, please. I like to think about the respiratory pathways that affect carbon dioxide in 3 different ways. One is from the top, which we think about the central nervous system being the respiratory center, that the child will not be able to breathe because of the signal not going to the muscles. Now, if the child can't breathe, this is related to the peripheral nervous system, such as in Guillain-Barré syndrome, where the signal does not go to the muscles, or the muscles are weak, such as in patients with Duchenne muscular dystrophy, or if the chest wall is abnormal in terms of deformity, and that can be due to significant scoliosis. In some cases, it could be the upper airway where the significant obstruction, so that could be obstructive sleep apnea that can cause a decrease in carbon dioxide elimination. And less likely what we see more in an acute phase due to the lungs, due to an obstructive disease where the lungs can result in can't breathe enough carbon dioxide. So we think about this as won't breathe, and can't breathe enough. Next, please. I think one important feature that we wanted to highlight is to differentiate between obstructive and central hyperventilation. So with obstructive hyperventilation, it is usually quite clear. We'll find the patient having upper airway obstruction symptoms, so snoring. There will be an increase in respiratory effort, and maybe sometimes what we'll have is paradoxical thoracoabdominal movement, and a polysomnography will show us flow limitation and some effort that is present. On the contrary, central hyperventilation is very subtle. There might be a reduced or absent truncal drive, where it might show as very shallow breathing. Those patients tend not to have obstruction if it's purely central. And on the polysomnography, we will have a flat chest and abdomen belt signals with the lack of a flow limitation, and there will be sometimes an absent drive. Next. Now, there are major categories that we want to think about when we think about hyperventilation. We did talk about central hyperventilation. One example would be congenital central hyperventilation or a CNS lesion, such as a tumor in pediatrics. These patients have a failure of the central drive and depressed carbon dioxide and oxygen chemosensitivity that affects the drive to breathe. The neuromuscular causes, such as spinal muscular atrophy or Duchenne muscular dystrophy, can cause the respiratory muscle weakness. These are progressive. And we have chest wall or skeletal abnormalities where we think about asphyxiating thoracic dystrophy, such as in Jones syndrome or scoliosis. These patients are unable to have an adequate tidal volume, resulting in restrictive mechanics. Next, please. Other causes that we have to think about. Back. Other causes we have to think about are obesity-related. We think about obesity hyperventilation. The clues are those patients are adolescents with severe obesity. They tend to have hypercapnia associated with obstructive sleep apnea that tend to improve with weight and CPAP therapy. Upper airway obstruction, as we've alluded to, could be because of adenotonsillar hypertrophy, in some severe cases craniofacial abnormalities, and those patients have very clear symptoms such as snoring, apneas, and noisy breathing. Very less likely causes to take into consideration that can cause hypoventilation are systemic causes such as hypothyroidism, electrolyte abnormalities such as hypophosphatasia, or people who are taking sedatives and opiates. These people have clinical clues such as global systemic signs or exposure to medication. Next. So one final key point we have to take into consideration in this patient that oxygen therapy did improve his oxygen saturation. But what we saw is that his carbon dioxide did slightly increase. And that takes into the factor the alveolar gas equation if we count a FiO2 of about 28% in this patient, considering the amount of oxygen he had, while breathing at sea level at a CO2 of about 80, we will see that when we calculate this and jot it on the oxyhemoglobin dissociation curve, we will see that the oxygen saturation does improve. However, we will see that this will not treat ventilation. In some instances, this might affect the carbon dioxide and the respiratory drive, and then the carbon dioxide may increase. Next. So to zoom in further on our case, we have to think about 4 major cases that sound like they are quite likely. ROHHAD is one of them. These patients tend to have a rapid obesity within 2 to 7 years of age with daytime hypoventilation that follows sleep hypoventilation. There's multi-axis hypothalamic dysfunction, and there is no genetic cause. In CCHS, on the other hand, it starts in infancy. There is central hypoventilation, no endocrine abnormalities, some autonomic dysfunction, and there's almost always a mutation, which is FOX2B mutation. Obesity hyperventilation in the pediatric population is not as common as in adults. We tend to see this probably in the adolescents with severe obesity, and it's driven by obesity-driven restrictive lung disease, and there is no genetic cause. While Prader-Willi syndrome, they have early hyperphagia, which becomes gradual, and then they tend to have mostly OSA, though sometimes will have central sleep apnea. The endocrine abnormalities we tend to see with them are growth hormone deficiency, hypogonadism, and the key point here is that we have a chromosomal abnormality. Next, please. So let's reflect back on our patients. There are certain kind of themes or umbrellas that we can group those manifestations. We have hypodipsia, polyuria, which is because of abnormal thirst sensation that has led to hypernatremia. We have hyperphagia that led to increase in weight gain, which is secondary to abnormal hunger sensation. There was a decrease in height velocity, as evident on the levels of the insulin growth factors, which were reduced. There was hyperlipidemia. Constipation, recurrent fevers, and hyperhidrosis all have an umbrella of autonomic dysfunction, with irritability reported, which can be behavioral. So we have components of symptoms that are hypothalamic, then we have components of symptoms that are autonomic and behavioral. And then there is the increase in weight gain. Next, please. So looking at all of this together and putting it all together, we came up with the likely diagnosis of being ROHHAD+. Next, please. Now, looking at this is a very nice algorithm taken for a CCHS flow that we can relate to. We had this patient who was confirmed to hypoventilation. The sleep study documented that. And then when you move down through the pathway on the left side of the screen, we see that the sleep-related symptoms were not worse when in quiet sleep. The genetic testing was negative. Therefore, we move to the further left of the screen, where we have to think about obesity, hypoventilation, and other clinical features which may fit Prader-Willi or ROHHAD syndrome. This is where the genetic testing might be helpful. If there is no hypoventilation, then it is less likely to be central congenital hypoventilation. This is where extensive investigation of the brain, the chest, the echocardiogram, the diaphragm, and pyridoxine testing for myasthenia gravis should be undertaken. Next, please. And this is where we think about all of this all together and come up with a rationale of why this is ROHHAD plus. Next, please. So when we look at this all together and compare it to all of the differential diagnoses that we came with, the other differential diagnoses are very unlikely. And the reasons are, we have central causes that have been ruled out by ruling out CCHS. We have a normal MRI of the brain. The neurological examination is very normal, which rules out a neuromuscular cause. There is no chest wall abnormality, which is not related to restriction. We have obesity. However, that obesity is not very classical of obesity hypoventilation syndrome, as it developed rapidly at age of 3. Then we do have a sensation that there might be some upper airway obstruction, though this child did not have adenotonsillar hypertrophy. His sleep study did show mild OSA. We do think about this being also obstructive hyperventilation that may be secondary to the gross obesity. Systemic metabolic causes that we have identified were a lot, and what we saw that the striking feature was the hypernatremia and the decreased levels of insulin-like growth factor. There was definitely autonomic instability that stood out with the hyperhidrosis, the recurrent fevers, the ophthalmologic manifestations, and the constipation. Next, please. So this is why we come up with the diagnosis of ROHHAD, which, as alluded to, is rapid onset obesity with hypothalamic dysfunction, hypoventilation, and autonomic dysregulation. In some cases, we can call it ROHHAD-NET when it is associated with neural crest tumors, which are associated with this condition. The challenge is that this is a diagnosis of exclusion with a careful pattern recognition. There is no confirmatory genetic test yet, and it's quite challenging given the limited cases of about 200 cases worldwide. And unfortunately, about 50% of patients do pass away due to cardiorespiratory arrest. Next, please. Now, it's not very clear why ROHHAD happens. There are many postulated causes, but it's likely multifactorial. We did say that there are no genetic causes. There have been studies of case series looking at zinc scan antibodies, hypothesizing that this is an autoimmune response. Then there are MRI imaging of a series of patients that have been inconsistent that documented hypothalamic inflammation. So it's still under investigation, and there are some promises when it comes to antibodies. Next. Now, when we look at this pathophysiology and clinical features, these are constellation of symptoms that I like to think about in 3 main categories. We have the behavioral and brain, then we have the systemic manifestations, and the neuroendocrine tumors. And what we see is that for hypothalamic dysfunction, what stands out is rapid onset obesity, we have hyperprolactinemia, and we can have precocious puberty, among many. Behavioral psychiatric issues, what we saw on our patients was behavioral outbursts. Then there are reports of anxiety or depression. Respiratory abnormalities that are key point is obstructive or central hypoventilation, obstructive sleep apnea or central hypoventilation, and autonomic dysregulation, where I think about it as an abnormal flight or flight response, where the sweating might be affected, the temperature instability, the either constipation or diarrhea, or ophthalmologic manifestations. We definitely can have metabolic features given the obesity, and there is the concerns regarding endocrine tumors such as neuroblastoma. Next, please. So when we look at the manifestations, we don't tend to see them all at once, but there are few that that are reported to happen quite common. So for the hypothalamic endocrine manifestations, what we tend to see are early rapid obesity in about 100% of patients. About 62% will have failed growth hormone stimulation test or hypernatremia, and 50% will have hyperprolactinemia or central hypothyroidism. When it comes to the respiratory manifestations, we see that in 100% of patients, and unfortunately, almost 60% will have cardiorespiratory arrest, highlighting the importance of vigilance in managing those patients. Autonomic regulation, tumors of the neural crest origin, and neurobehavioral disorders can occur in about 50% of the patients. So knowing that, not everything will be very clear, and it's a challenge to identify the causes. Next, please. A key thing to know is that there's a sequence, and knowing that this sequence happens tells us that, we have to keep an eye on those patients. And that's also part of the challenge in diagnosing such patients. We have rapid onset obesity that happened similarly to our patient and occurred at around 3 years of age. Those patients will tend to put up to 10 kilograms in the first 6 to 12 months when this starts. Hypothalamic dysfunction follows, and then autonomic dysregulation will happen. Hypoventilation usually will happen in about 83% of patients within 5 years of age, or about 2 years after the initial rapid onset obesity. Keeping in mind, neuroendocrine tumors may happen in up to 50% of cases, and that should be taken into consideration when patients present with obesity and neuroendocrine tumors. Next. So the diagnostic challenge here is that there's no specific biomarker. However, the zinc scan and autoantibody is promising but is unvalidated. The delay is in diagnosis because the presentation is very variable. It's often misdiagnosed when we see those patients with obesity due to nutritional or syndromic obesity. The key point here is that it requires multidisciplinary evaluation. Next. So ROHHAD, what the literature has agreed on is that there's rapid onset obesity in a previously healthy child with hypoventilation, hypothalamic endocrine dysfunction, and supportive evidence of autonomic dysregulation, clearly highlighting the importance of exclusion of genetic, neuromuscular, structural, and syndromic causes. Next. Now, this is a diagnostic algorithm that I find quite very helpful. And what we see here is that there is a group of so we have rapid onset obesity together with central hypoventilation. And what this algorithm says is that we have to rule out genetic causes such as CCHS and Prader-Willi syndrome. If these are negative, then we have to think about central causes where we have to consider doing an MRI of brain to exclude structural causes of the brain that can cause hypoventilation. If these are excluded, then we move down to looking at other possible constellation of symptoms, so at least one other feature of hypothalamic dysfunction, or at least one feature of autonomic dysregulation. If this is not there, then there's a probable diagnosis of ROHHAD. We probably need to watch out if there are further symptoms that develop. But if these meet criteria, then we have a confirmed diagnosis of ROHHAD syndrome. A key point here is that now if we have a ROHHAD syndrome, we have to survey for neuroendocrine tumors by either considering an MRI whole body or urinary catecholamines, considering that we have neuroendocrine tumors. And if these are detected, then we have to call this ROHHAD-NET syndrome. Next. So, looking at this case, see it's quite interesting, and we think about this being as ROHHAD plus obesity-related hypoventilation. Now, this question will be addressed towards the end. Thank you. Next.
Thank you, Majid. So I will go on. So next slide, please. I'm sure after Dr. Majid's talk, we all will agree that this child has ROHHAD syndrome, as he had sleep-related hypoventilation, and the symptoms are absent during the first few years of life. And also the patient has at least two of the following: rapid onset obesity, endocrine abnormalities of hypothalamic origin, and severe emotional and behavior disturbances. And also, there's no mutation of FOX2B, and the disorder cannot be better explained by other sleep disorders. And also, he has autonomic dysfunctions like sweating, persistent fever, and constipation, and eye problems. So his obstructive hypoventilation might be secondary to the obesity, and also he had recurrent pneumonia and the eye problem. Next slide, please. management. So we give this boy nebulizer because he has severe cough and has a history of atopy. And with the nebulizer, he had a good response. And also we give the liraglutide injection subcutaneous for weight control, and also ask him to keep a good dietary. And besides, very importantly, we give him non-invasive ventilation therapy. Next one, please. Next, please. Here we give him the BiPAP ST mode. The IPAP was 17 and the EPAP was 8. The respiratory backup respiratory rate was 18, and oxygen, and also he triggered by himself. From this slide, we can see that this is during his REM sleep. With the BiPAP, he had much better saturation, and also the CO2 dropped down a little bit compared to before when he was without any treatment. Next one, please. And here, this slide shows the tidal volume. Yeah. Okay. So this slide shows when with the BiPAP, the paradoxical breathing disappear. So this might be due to his obesity and then result in obstructive hypoventilation. Next one, please. Next, please. Okay, the hippogram. So we see BiPAP. He still has a little bit OHI, but the average SpO2 was above 98%, and the average CO2 is around 76 milliliter. So it's much better compared to before when he was only in room air. Next one, please. For the follow-up, we called him. We called him just in August this year, and then the patient lives far away from Beijing. He's in south of China, so the parents have to work. So they take their child to the local hospital near Shanghai. Recently, there's no recent adjustment, so still he's using this BiPAP ST mode with IPAP and EPAP as 17 over 8 centimeter, and the same mode actually. And then he used 3 to 4 nights per week during the sleep, but compliance is it's not too bad, as once he will use the whole night. And he had a much better blood gas in the local hospital in the daytime. The CO2 dropped down to normal, and the BE is normal, and with a good saturation. Next, please. So here's the questions. So could you please make your choice? Thank you.
Okay, most of the audience answer E around 47% do all of the above, and around 26% answer the volume target, and 0% for increase backup rate, and 20% for increase the trigger sensitivity, and the 5% for the increase the IPAP. Okay, so interesting answer. Okay, so today I will cover two topics: the high CO2 and the unsatisfied the compliance of the NIV. Next. So this is the polysomnographic tracing, and look at the carbon dioxide. He still have the very high carbon dioxide. Even the doctor give the BiPAP already. So what we can do after this talk? So next slide, please. During the BiPAP titration, what is the difference between the titrate bedside and the titrate under polysomnography? To do the titration under polysomnography, we will see the worst state of the patient, especially the REM sleep and the supine position. So we can adjust the pressure to help the patient better than the bedside. Next slide. So there are three factors to consider when we use the NIV: the patient and the equipment and the doctor. The doctor should treat the patient complication and correct the equipment, for example, mat fitting and ventilator settings. Next, please. To do the positive pressure titration during the night for the obstruction, we normally increase the CPAP pressure to get rid of the apnea, hypopnea, snoring, and desaturation, and use the BiPAP when the CPAP pressure is too high and the patient feel uncomfortable, or the CPAP pressure induce central apnea. And normally we will increase the EPAP to get rid of the apnea, and the IPAP to get rid of the rest. Next slide, please. For the follow-up in 1 week is very important because it will predict compliance in the future. For the remote monitoring, when the patient use the machine, and the information will send to the cloud, and the sleep center can access the information, and the doctor can read the medical report and see the compliance and referee event, and can adjust the ventilator setting. The command, the good command should be use the machine at least 4 hours per night, at least 70%. For example, 70 days in 100 days, and try to keep the HI less than 5 times per hour. And unintentional leak should keep less than 24 liters per minute. And in BiPAP, sometimes we should see the trigger sensitivity. We may adjust it to make the patient comfortable. Next slide, please. And how to increase the NIV compliance. Normally, I usually start with this. Start with the positive reinforcement, and I usually ask this question to the patient: can you tell me the secret why you did so good? Or you can give the sticker. It's really help. And during the conversation and take the physical examination, I will find and treat the NIV side effects and adjust the ventilator setting. For example, initial pressure, pressure relief, lamp times, and minimum and maximum pressure and humidification. So this way will make the patient comfortable. Next slide, please. Come back with the case. So the patient already have the BiPAP and the CO2 still high. I would increase the IPAP first to help the breathing, and after that the oxygen will getting better, and I will try to decrease the oxygen because sometimes the oxygen can cause the CO2 narcosis, as Dr. Majid said. Okay, thank you.
Next, please. So I think this is similar. When he was we follow up and call the parent. Now his height is 132, weight is 54 kilogram, and BMI is 31. So decreased, his BMI decreased compared to when he was 9 years of age, and the child was only treated with liraglutide for 1 week after discharge, and he did not use it. And he still has persistent fever. The temperature fluctuating between 38 to 38.2 to 38.5, normalized in autumn and winter. The
Next one. So could you could the audience cast a vote on the treatment of obesity in ROHHAD? A, caloric restriction, B, better support, or C, tonsillectomy, or D, A plus B?
Oh, sorry, I didn't open my mic. Sorry.
It's okay, Faye, thanks. So it's very good. Okay, so let's move on. So thank you very much. The next, please. So you can actually see the cross-matrix obesity and the hypoventilation, be it central and obstructive. Next. So obesity and sleep or disordered breathing come together, intertwine, and one aggravate the others and become vicious cycle. So it's very important to decrease obesity. As it is as important as NIV for sleep disordered breathing, because both are contributing to the sleep disordered breathing. So it's important to provide the exact calorie intake. It's good that patient is mentally retarded, so that the intake will be governed by the parent. So it's important to know the resting energy expenditure, the REE. And I appeal to you all to try to use more the indirect calorimetry in your lung function laboratory. So when you buy a body box, a lung function machine, please try buy one that can allow you to do indirect calorimetry that allow you to calculate the calorie requirement. And that also adequate ventilator support is important to decrease the leptin resistance that lead to more hyperphagia. Exercise is important, but it could be dangerous. We need to do an exercise tolerance assessment for this patient so we can tell the parents what exercise they can do. Usually it's a moderate exercise. Growth hormones should be considered to increase the muscle mass and decrease the fat mass, increase stature for this patient. And we can think about using medications like tirzepatide, or at the end, if the obesity is not controlled, then we can consider bariatric surgery. Next. So the next medications he was trying on is liraglutide, which is a glucagon-like peptide, but the effectiveness is only about 5 to 10%. So in this gross morbid obesity, I think this the newer medication, the tirzepatide, which is glucagon-dependent, glucose-dependent insulinotropic polypeptide, the GIP, and the GLP-1 achieve a much better weight loss. So the team may like to consider it to be helpful to control obesity, which is important to control the sleep disorder breathing. Next. So how do we improve the compliance? We cut about 55% to more than 75% to identify and solve the problems and educate parents on the benefits of good compliance. It's absolutely important. We have the patient already mentally retarded, so we want to preserve all the intelligence he can have genetically. Next. So problem solving is important for us. Next. So it looks for leaks. Okay, so for him, the leak is not too much, but if the leak is a lot, cause insufficient ventilation, irritation eyes, and very noisy. So make sure the mask is good fit, that the headgear strap is good. If this still persists with the nasal mask, you may like to change your oval nasal mask or a full face mask, or use a nasal mask with a chin strap. Next. There could be asynchrony between patient and ventilator. The patient, it could be because the patient could not trigger the ventilator. So what we can do is to adjust the sensitivity of trigger or to decrease the back-out rate so that they allow the chance for patient to trigger the breath. Or the asynchrony caused by the mouth breathing with significant air leak. Next. There may be a pressure ulcer over the nose, so it's solved by decreasing pressure, change interface, or use protective skin dressing. Next. It could be due to nasal discharge, rhinitis, or epistaxis. You can use a vasoconstrictor like Otrivin or nasal steroid. It's very important to use heated humidification. A lot of centers do not use it routinely, and I caution against it because humidification is very important, especially the heated one. Next. And then if there's some troublesome cough, usually due to cool and dry air, so or postnasal drip, the solution is to use heated humidifier with circuits having heated wire to decrease the vapor loss in the circuit. And we can use that nasal topical steroid to control the postnasal drip. Next. Prolonged use of NIV could cause midface hypoplasia. It can be prevented by using a different interface throughout the week. And then also after it occurs, we can treat it by using reverse headgear to pull the midface out. Next. Equipment maintenance is very important for home use, long-term use, so we must educate parents on proper disinfection, the proper timing of changing a filter, and make sure the mask and the circuit are not too worn out, leading to problems like leakage. As infection is very important, so disinfection is very important to prevent Pseudomonas infection in this heater humidifier. Next. So I'm going to give an example. 11 years of severe OSAS, 144 per hour, pending TNA, nadir is 42%. Next. So see on auto CPAP, 4 to 12 centimeter water. Next. You can see from the right-hand side oximetry is a cluster of severe desaturations, okay? And AHI dropped significantly, but still quite high, of 41 per hour. You can see on the left-hand side, the middle column, the very frequent apnea, and the pressure of the machine is already at the maximum limit. Next. So we increase the IPAP to 18 to try to overcome the obstruction. Next. So you can see that with the higher IPAP, the AHI decrease, but still quite is 14, and it's quite the saturation is less, but still there. So next is what you set, a volume target 1. Check next. Next. Go back 1. So this is AWAPS, the volume target 1. So we set target tidal volume 250, and then set maximum pressure. So the saturation you can see from the right-hand side is much improved upper row. But you can see that on left-hand side, the trigger is only about 14%. So we would like to more triggering. So what we need to do is to drop the back-out rate from 18. Next. Okay, so drop the back-out rate to 10. You can see now the patient trigger to 92%. Okay, so now we have this machine that can monitor remotely, and the saturation monitor that we can monitor remotely. So even from Beijing, you can monitor the patient in Shanghai on a weekly basis. Next. So, I mean, this patient more than hypoventilation. So as Majid mentioned, is depression, anxiety, and behavior change is very common. And so it's important for us to provide actual support, family counseling for caregiver who is invariably highly stressed. And we must try to provide some relief for caregiver, okay, and provide hospital at home service. Next. We also do a tumor surveillance regularly to rule out the neuroendocrine tumor and monitor the urine for VMA. Next. Next. GI tract, so we must ensure that bowel motion every 1 to 2 days. We must look out for reflux. It's common for them to have it, elevated head of bed. We must look out for GERD, especially for those with recurrent pneumonia in the absence of immunodeficiency, because a lot of pneumonia may actually be due to aspiration from the reflux or from the dysfunctional swallowing. Next. Mortality is high, so we need to make of that kind of west. So we may need to discuss about the need for tracheostomy if the patient needs NIV subsequently. It's also important for the team to think about the quality of life for this patient. Next. So for complex case home care, it's very important to provide support at home from the treating team and the clinical care to promote health and early treatment of diseases, and psychosocial support for parents who are at great stress that not uncommonly lead to tragedies, i.e. a homicide of the kid and suicide of the parents. Next. So I'm going to present in the next few minutes of the hospital at home service in Hong Kong, a charity service funded by donation. Next. So the charity is called Families of SMA. They spin out a program called Next. Mercy Medical Management. Next. They cater for all these technology-dependent children to decrease the burden on hospital and decrease cost infection in hospital and provide relief for parents. Next. So we send out a team of nurses and technicians who do assessment on site for the patient with technician providing monitoring of carbon dioxide and CO2 and checking of the machine. Next. So the doctor will assess the patient before, draw the plan, while the on-site nurse will follow the plan and check all this examination, ventilator, educate the parents, and on-site adjustment in real time, the pressure adjustment. And we can do all the overnight sleep test, transcutaneous CO2 as well. Next. So the technician set up the CO2 and oximetry, and we can also do a home lung function. You can see here the ventilator checking, the CO2 monitoring. Next. And we can also do a lung function now with this portable FOT machine, so that you can do tidal breathing lung function. Next. So and then we can download a report, and then we can remotely assess how satisfactory the ventilator support is and adjust it remotely. Next. So it's important to provide psychological support for carers. So clinical psychologists and buddy program are provided so that we run workshop for the parents. We run buddy program. Buddy program is a lay person who become a friend of this parent, and then they take him or her out for lunch, for a time away from caring of the sick kid. I think it's very important to provide this holistic care. Next. So in conclusion, we have this patient with ROHHAD syndrome, which lead to obstructive hypoventilation also, and also could have short stature, and also the ROHHAD cause GI dysmotility that potentially cause aspiration. So I think it's important for the team to ask ourselves the reason for recurrent pneumonia is due to aspirations. So whether we can prevent it from leading to further problem in the lung parenchyma, leading to more desaturation and more CO2 retention. So I think it's important for this multiple organ system dysfunction sick child with technology dependent, have intense coordination of different subspecialty teams under one team leader. So I think Professor Su has a important role to play to coordinate the different teams to provide a more wholesome care, both from the cardiovascular point of view, from the neuropsychological point of view, the palliative care and so on. So I think it's important for the whole team to come together, and the distance now is not a problem. Even the patient is in Shanghai, we can remotely control the ventilator and so on. So hopefully together we can make a change to this unfortunate kid and the parents, so that they live a more fruitful life. So thank you very much for your attention. I hand the mic back to Professor Kuning San. Thank you.
Thank you so much. Thank you so much for all of you, your four speakers. Actually, we get a lot of information from your the brightest mind in the field to share with us your experience. Especially Dr. Daniel Wu introduced the experience in Hong Kong about the foundation of SMA. And also it is very important for multiple discipline treatment. Our goal was to enhance understanding of hypoventilation for an overweight child. Actually used this case to improve our diagnostic skills and ultimately provide the highest quality care for our children. I would like to extend my gratitude to all the speakers and the participants who have joined us today. And also, I would like to announce that our next grand round will be November 28th. Please book the time on your calendar, and we are looking forward to meet you in the next event. Thank you so much.
Thank you.
Thank you. Thank
Thank
you.
you.
Thank you so
Bye-bye.
much for all of you. Bye bye.